Hi, everybody. My name is Erica Ferriston. Welcome to the Healthcare for All Los Angeles Speaker Series. We are so excited tonight to have Dr. Sarah Deen. For those of you who are new, Healthcare for All Los Angeles is a local chapter of a statewide organization, Healthcare for All California, that is dedicated to achieving a universal healthcare system through single-payer public financing. Our goal is that all California residents have comprehensive, high-quality healthcare. We have a bill right now, AB 1400 CalCare, and that is what we are working on. So it's Ramadan, the month of fasting for our Muslim brothers and sisters around the world. Many of them will be breaking their fast at actually right now at 7:32. And so our guest speaker, Dr. Sarah Deen, is breaking her fast by praying the sunset prayer. And so while she does that, she has offered a Ramadan song for us to enjoy and partake. So Paul, could you go ahead and play that?
Oop, let's get some.
With hope in our eyes, we search through the skies, waiting for our old friend. With loved ones nearby and our spirits high, a blessed time we'll spend. In both love and in fear, to Allah we draw near, hands raised to the sky. Oh Allah, please forgive us and guide us to paradise. Ramadan is here, Allah's mercy is near. Time to give, time to share, time to show we care, 'cause Ramadan is here. Day and all night, no more words will recite, healing our hearts with Quran, revealed on the night of power, a guide for this world to the end. Like past nations have done, we'll fast for the one creator, from him shines all light. Oh Allah, please forgive us and guide us to paradise. Ramadan is here, Allah's mercy is near. Time to give, time to share, time to show we care, 'cause Ramadan is here. Friends and family will break bread and be thankful for all we have. Spending our nights in prayer, a chance for a brand new path. A month to let go of grudges we hold, time to make it right. Oh Allah, please unite us and guide us to paradise. Oh, and guide us to paradise. Ramadan is here, Allah's mercy is near. Time to give, time to share, time to show we care, 'cause Ramadan is here. Ramadan is here, Allah's mercy is near. Time to give, time to share, time to show we care. 'Cause the dawn is here. Whoa, the dawn is here.
Thank you, Paul. You can go ahead and stop sharing. Oh my gosh, that was great. I was rocking out. I don't think I've ever rocked out to a Ramadan song, but woohoo, that was beautiful. Ramadan is here, and so is Dr. Sarah Deen, and I'm so excited to have her speak with us tonight. Dr. Sarah Deen was born in California and earned a bachelor's degree in molecular and, oops, let me go ahead and mute. Yeah, if everybody could just go ahead and mute themselves. So she earned a bachelor's degree in molecular and cell biology from UC Berkeley and a dental degree from UCSF. With advanced cosmetic dentistry training, Dr. Deen established herself as a sought-after dentist in Fresno. However, to accommodate her husband's medical training in 3 different states, Dr. Deen transitioned to teaching at 2 dental schools, UCSF, Case Western School of Dentistry, while raising their 2 children. In 2013, the family returned to California. Dr. Deen completed a year of advanced education in general dentistry at UCLA, began teaching dental residents, and assumed clinical practice in Torrance. In 2015, as the Muslim American community felt rising Islamophobia, Dr. Deen began organizing at the local mosque to address American Muslim identity formation, interfaith collaboration, and civic engagement. This led to board appointments at Bayan Islamic Graduate School and the South Coast Interfaith Council. In 2017, Dr. Deen stepped away from dentistry entirely to focus on interfaith work, pursuing social justice and civic engagement. She also serves as a delegate from the 66th Assembly District to the California Democratic Party. And with that, I will turn it over to Dr. Sarah Deen. Welcome.
Oh, thank you so much. Greetings of peace to all of my friends out there and everyone here with Healthcare for All Los Angeles. I first really want to thank Erica and the team here for their loving inclusion of my community today. Erica asked me if I would be willing to be the speaker today, and I said, I would love to, but I have to break fast at exactly that time. And Erica said, well, bring that with you, share that with us. And so I'm super excited to share. I am going to explain a little bit about why I'm fasting, but right now, people, Muslims in California are about to break fast, or they just broke fast. Different Muslims observe the timing slightly differently, but I wanted to share. So I put it out on Facebook World Land that I'm going to be breaking fast on Facebook Live, and my community has been shipping food to me all day long. I am not joking. So I have to do justice to my friends that dropped this food off and share with you. So these are some examples of traditional iftar, which is the food that you break your fast with. So classically, most Muslims will break fast with a date, yummy, delicious, quick source of carbohydrates. It's like an electric current through your body when you haven't had any food or water all day long. And then displayed here, you've got a lot of food that friends dropped off. So my parents are from Pakistan. So they traditionally will add a samosa. I'm guessing a lot of you guys have seen these little fried triangles. They can have meat, they can have potatoes. Here is a Lebanese family locally dropped off fataya for me with spinach in it. Actually, they dropped off 3 different kinds. So they've got a cheese one and one with minced meat. I have from my community members in Palestine, from Palestine, I have mamoul. I think traditionally they eat this for Eid when the month ends, but I got lucky. I got it in the middle of the month. And I just have to share because these people went through all this trouble. My Sudanese sister dropped off a traditional meal from Sudan, and she said this is fool, and this is what I think we commonly call it falafel. I think the Sudanese have a different term for it. She dropped off like a 4-course meal. So I've got some meat here. I'm doing my best to show you guys because she went through all this trouble. I have to share it. There's a yogurt dip that goes with it, and then garbanzo beans with dates. And she also dropped off, and I'm gonna pull up the name of the drink because I had never even heard of this. So this is holamur from Sudan, and she said it's sweet and sour. So should I take a drink while we're live here? Okay, hopefully my face is way too expressive, so hopefully my facial expressions are kind. Wow, okay, it is exactly as she said, sweet and sour. It's really good, and it has a really good aroma to it. Friends, do wish them a happy Ramadan and see if you can sucker them into sharing an iftar meal with you. So these are just some of the ways Muslims break their fasts. What is Ramadan? So this is the month of fasting for Muslims. And like many other faith communities, fasting is a way of breaking us out of our routines. So once a year, it's a month-long disruption in our routine so that we can become more intentional with how we use our time and our bodies. And so we can be more mindful about our interactions with other human beings and creation. When you experience hunger and thirst in this way, you really become aware of your ego. And hopefully that awareness stays with you throughout that year. It's the ego that leads us to ingratitude and arrogance. So if you consider, and believe me, I'm going to come to healthcare. That's where I'm going. Hang in there with me. So if you consider any of the greatest prophets and sages, it was their grounding in humility and gratitude that birthed their unconditional love and care for human beings. That's what was revolutionary about them. The lepers were those who were not considered safe nor deserving of human contact and care, but Jesus went out of his way to care for them. In Prophet Muhammad's time, the orphans and the poor, they weren't considered anyone's time, and Prophet Muhammad, blessings and peace upon him, went out of his way to take care of them. Society told these prophets that the lepers and the orphans didn't have the capacity for anything more, that they weren't anyone else's problem. These prophets and sages were revolutionary in pushing back against the status quo and insisting that every human is a sacred carrier of the divine spirit and deserves unconditional love and care, and that it was every person's responsibility to unconditionally care for one another. So rituals like fasting, which, like I said, Muslims fast, Catholics fast, Jewish communities fast, Buddhists fast, it's shared in many traditions. Fasting helps us discipline the ego so that we can carry on that legacy of our sages throughout time, their legacy of unconditional care for one another. So how do we translate those values into our world today? How do we uphold the unconditional worth of the human spirit through care today? We don't live in villages or city-states anymore. The way humans are now organizing themselves, the way we translate those values, it's into policies. I may not be in a position to physically care for the leper or the orphan, but I can use my voice and my vote to ensure policies which uphold unconditional care. In a democracy, we collectively design our systems of care. And that's why, as a Muslim dentist, I am here today to talk about healthcare, because our current healthcare system is a disgusting violation of the human spirit. And what aspect of care is more important than the protection of one another's health? Today, our system only cares for you if you're employed a certain way or if you have certain immigration paperwork. You have to prove you're worthy of healthcare. You have to prove that you're worthy of care. Another activist said this today. We have a caste system in place when it comes to our healthcare. We're ranked in our worthiness for healthcare. Some get healthcare immediately. I'm having an issue with my eyes. I happen to be married to a physician. I have the luxury of being able to access healthcare. I called today and made an appointment. My friend, my Sudanese friend who dropped off this beautiful meal, she is here legally as a refugee. She filed all her paperwork exactly as it should be filed. She is not eligible right now for healthcare. She tells me every day, sister, I can't afford to get sick. My sons are counting on me. I have to stay healthy. The only coverage she has, this is the state of our country today. If she gets hit by a car, if something, God forbid, happens to her, she will have enough coverage to only be revived, to be resuscitated, to then struggle with lifelong illness and injury. That is all she's covered for. How is that just? How is that unconditional care that our sages and prophets practiced and demonstrated? And as a dentist, I haven't shared the story in that many spaces yet. I walked out of the dental practice for years because of how absurd our system is. I worked at a practice. I was not the owner. I was an employed dentist. And there was a gentleman that was employed by the corporation that ran our office. And this young man, he was no more than 24 years old. He was in the office all the time, taking care of our tech support. And we always had tech issues. So at least twice a week, he was in our office. Less than 24 years old, I could tell that he was about to lose most of his teeth. There were swellings that were visibly obvious. I could see that he was in pain. So I asked him, "You're in a dental office every week. Why aren't you taking care of your teeth?" I cannot still wrap my brain around what he said. He said that the health insurance that was offered to him through his employer, the dental office he worked at, was not considered an acceptable form of payment by the office. So the dental office he was working for did not accept as payment the very insurance they were offering their employees. That is an absolute absurdity. And so in my off time, I told him, okay, we're gonna take care of you during my lunch hour. And so I took care of him during my lunch hour. I then was out of the office on vacation for a month, started getting these frantic phone calls from the office admin and other folks. The owner dentist was really upset at what had happened. And instead of coming after me, they were coming after all of the staff that witnessed me offering dental care to this person that was in acute pain. According to current laws in California, as a dentist, I'm allowed to set my fees. It's absolutely my right to extend care, as long as I'm not using resources that don't belong to me. It's not the office's fault. It really isn't. It's the system. And there's a particular villain in the system that I want to talk about today. When I took my first job as a dentist, it was at a private practice in Fresno. And I remember the office owner telling me, you have 2 chairs. So every dentist at that office, there were 3 of us, had 2 chairs. She said, one is your HMO chair. That is exactly her words. This is your HMO chair. This is your private chair. Between these 2 chairs, you are to generate $6,000 of revenue every day. I am telling you all exactly what I was told as a new dentist. She told me, you can do it any way you want. You can see 500 patients in your HMO chair to get to the 6,000, or you can curate a patient pool that's mostly private so that you can see fewer patients and spend more time with them. What was I to do? I had to get paid. I had to pay my student debt off. I had to be able to pay rent, but I needed to practice ethically. So I started shifting. I started trying to accrue more patients that could pay cash or that were of better insurance so that I could spend quality time and deliver healthcare that I thought was ethical. What about the HMO patients? It's because they're covered under capitation systems. And I'm gonna get into that later. So I really want us to think about the role the insurance industry plays right now in disrupting the relationship between patient and doctor, patient and healthcare provider. There is a third party that's constantly in the middle of what should be a very sacred relationship disrupting and not allowing the patient's health and well-being to be meaningfully addressed. Okay, so why are we here today? There was an incredible bill introduced into the California State Legislature this year, and I want to talk a little bit about that. So I'm going to pull up my little PowerPoint here. Bear with me. Okay. So why? I hope we've kind of established that the system we have in place right now, the system that reflects all of our values, keep that in mind. Systems are implemented by the people that put them in place. That's us. It's on us. If my Sudanese friend is unable to have her blood pressure medication or to see a doctor when she needs it, it's on each one of us. It's on people like me who are able to access healthcare. So too many Californians are without coverage or have inadequate coverage. And regular folks like us are having to pay more and more of our healthcare costs, whether it's through copays, deductibles, premiums, or things that are covered that are not covered by our insurance. Small businesses are having to foot the bill for increasingly expensive healthcare insurance. And there are wide disparities of care between socioeconomic groups. There are many social determinants of how well your health is going to be taken care of in our communities. So in the current state of affairs, a person of color, a person of lower income is going to have less access to healthcare. I don't see that's fair. I don't see how Jesus would have stood up for that. So again, this bill, AB 1400, was introduced to the California State Legislature on February 19th, 2021. You can see some of the folks who helped co-author the bill. I'm going to come back to this at the very end, but I just want to mention it in this moment. Last week, this bill was kind of put into, the bill is not going to be considered in committee right now, and we're going to come back to that. The bill is still very much active, and this is the time where activists and people who care like us need to start telling our legislators, we're not going to tolerate this kind of a healthcare system anymore, where people are not treated as equal and don't have equal access to healthcare. I'm going to come back to this point. But what is AB 1400? So it's a piece of legislation that establishes CalCare. CalCare is a governance board of 9 people, and it all with these two 11-member advisory committees. There's a CalCare trust fund that will pay for, that's the single payer that would start paying all of your insurance claims. It's a public network of institutional providers and healthcare providers, and I'm going to define those terms. So like I said, single payer, institutional provider, healthcare provider. We need to understand what those things are. Here's a little graphic that explains what this means to people like us. So on the, I think it's the left of your screens, you see where it says CalCare. You see CalCare, there's these purple arrows with dollar bills on them going to things like the hospital and the nursing home. Entities like hospitals and nursing homes would become what we call institutional providers if AB 1400 passes. These institutional providers would receive a global budget annually from the CalCare fund. The global budget could be appealed by an institutional provider. Like an institutional provider can say, hey, CalCare, we had a really tough year. There was a natural disaster, our equipment broke down, whatever. We need an increase in global budget. So there is that capacity built into the bill. Within the global budget is included the salaries for doctors or healthcare providers who choose to be salaried and employed by these institutional providers. There are also within the bill, or you can be a healthcare provider, doctor, dentist, physical therapist, who chooses to be fee for service. You would receive payment directly. Those healthcare providers would receive their payment directly from CalCare. And here's an unusual thing. Usually, healthcare providers are not able to collectively negotiate for their salary, which is their fee for service. CalCare allows the healthcare providers to negotiate their fee for service rates. As a patient, you're here on the pink side. You can go to absolutely any healthcare provider you choose to go to. You can go to any institutional provider you want to, and you're not going to pay a cent when you go show up at the doctor's office. The payments are going to be handled by CalCare through the global budget or through the fee for service. How will patients be impacted? Again, you don't need a referral. You can choose any provider you want. Every resident of California is 100% covered. Establishing residency will kind of look like establishing residency to attend university or college here. Your dental care is going to be covered. How ridiculous is it that Medi-Cal right now will pay for your tooth to be extracted, but not a meaningful way for you to replace that tooth? How the heck are you supposed to eat? If you can't eat, you're malnourished. If you're malnourished, you are not healthy and able to go to work or study in school. Anyways, that's my little dental tangent there. And one thing I want to emphasize again, CalCare equalizes care. It ensures that every single one of us gets the same quality health care. And it centers treatment choices because they're going to be made between the healthcare provider and the patient. The insurance industry is not going to be meddling in the middle. Are the undocumented covered? Yes. Unemployed? Yes. Working poor, pre-existing conditions, in people who are in home receiving long-term care? Yes. What happens to your Medicare? You get to keep it. You get to keep it, and CalCare will pay all the little supplementary, the Part A, Part D, all those other extra parts that you are worried about. CalCare is going to fill in all the gaps for you. What about the healthcare insurance workers? Won't they be left without jobs? CalCare has written that into the bill. There is a just transition so that nobody is left behind. They've put a lot of energy and effort into making sure that the most vulnerable people are addressed. They're honoring the humanity of every human being. So if you're an insurance worker, you will get first dibs at job training and job placement. There will even be a fund created to allow that to happen. It's spelled out in the bill. What about healthcare providers? People like me or my husband, how will it impact the practice of medicine? Very important to remember, currently as it stands, the insurance industry determines medical necessity. When you graduate dental school, medical school, you take an oath that you will treat patients to the best of your abilities every single time. Do you know how much it used to kill a little small part of my soul every time I had to tell a patient, this is the best care for you, but your insurance won't cover it, so you're going to be stuck with this. That's not right. That's not right. What you can afford should not determine your access to healthcare. The insurance industry does not take an oath to protect us, does not take an oath to take care of us as human beings, does not take an oath to offer us the best healthcare. The insurance industry is a business, which is okay. Their goal is to cut down costs and increase profits. We have to keep that in mind, especially when there are arguments being made that single payer isn't the only way to go about it. Yes, until the insurance industry is removed, there's a cancer within our healthcare system. We have to remove the multi-payer health insurance industry right now because its agenda directly opposes the well-being of patients. We'll talk more about that in a minute. I hope I'm keeping time a little bit here. Okay, how will it impact patient care? Healthcare providers will determine medical necessity. Your provider who is seeing you, who is treating you, who has talked to you, who knows what is going to be best for you is going to determine medical necessity, not the insurance industry. Providers will no longer have to seek pre-authorizations. And there's a lot of studies done on this that seeking pre-authorizations does not meaningfully lower costs of providing care. It only creates impediments and prohibits timely care of sometimes life-saving healthcare. Providers will not have to implement step therapy protocol. This is the one I find most people are shocked about. So a doctor is seeing their patient. Doctor knows that drug C is the best choice for their patient. Insurance says, sorry, doc, we know drug C might make more sense in your case, but drug A is cheaper. We want you to try drug A for 3 months. When drug A doesn't work, then we'll let you try drug B. When drug B doesn't work for another 3 months, then we'll go ahead and pay for drug C. In that time, the patient's health has deteriorated. We are all saying this is okay right now. As long as we permit insurance companies to persist, we are saying that this is okay. Number 7 is also a really interesting one. AB 1400 prohibits risk sharing or risk shifting mechanisms. I have heard a lot about this from my husband, who's a physician in the South Bay. They're called ACOs. An ACO is an entity when doctors or providers come together, and what they say is, okay, docs, if you can reduce costs when we bill Medicare, we're going to save some money on our annual Medicare reimbursement. If you can cut down the costs, whatever we save this year, we're going to kick it back to you. Okay, so doctors are given an incentive to kick patients out of the hospital sooner than they're ready. And I cannot tell you the number of times my husband has come home bereaved and distressed because of this very situation. It's not something that happens sometimes. It happens every single day in our hospitals, in our healthcare systems, where doctors who are vulnerable, they got student debt to pay. They've got to be able to pay their rent too. Doctors are human beings. They're incentivized to reduce costs, reduce care to patients, and then whatever the group, the ACO, saves on their Medicare reimbursement that year, that entity takes usually like 20% cut is what I've heard in my husband in this region. I will not list one of the IPAs by name, but a local IPA that is involved in the South Bay, they keep the administration cost of 20% and they kick back the 80% to their doctors. It also stops capitation schemes. What is capitation? Capitation is the reason that my first dental job, they told me this is your HMO chair and this is your private chair and you can use them as you wish. So what capitation is, for my HMO patients, I get a set number of dollars for those HMO patients per year. I'm gonna make up numbers so it's easy to talk about it. So maybe I get $500 a year for every one of a particular HMO's patients. If that patient comes in 10 times a month, I'm not gonna get reimbursed anymore. I'm still gonna just get that little amount that for the year, right? So what's gonna naturally happen? My HMO patients, I don't have a reason to spend time on them. I'm not gonna get reimbursed any better to take care of them in a mindful and meaningful way. So it becomes a volume game, right? I wanna get them out, I wanna get them in, I wanna get them out because I get paid per patient per year. So the more patients I'm technically willing to see, that's the larger payment I get from the HMO for that year. What is the HMO doing for me? It's providing me with a pool of patients, which is why dentists will often sign up with an insurance company. Second, a dentist develops a reputation for excellence, they get rid of those insurance companies. Do you remember when your dentist's office told you they're not taking your insurance anymore? That's why. Your dentist had now developed enough cash paying patients or the premier, there's one or two in dental insurance companies that offer a better payment to the dentist. That dentist basically is now operating in a place where they don't have to deal with the HMOs anymore. So they've dropped your care because it doesn't make financial sense for them. Dentists, doctors are human beings. The overhead for a dental office is 60%. Again, people have families. You got to be pragmatic, but the problem is the insurance industry incentivizes cost reduction, right? It makes it a game of bulk, quality over quantity. We all learned when we were in school, we should always go for quality. Why not in our healthcare? All right, enough ranting on that. Under this bill, under CalCare, the wellness and consent of a patient will be prioritized instead of lowering costs and increasing profit margins. I've said this in other places. Making money isn't a crime. We all need to do it to put food on the table. But prioritizing making money over the welfare of human beings, that is a sin. My belief. You can draw your own conclusions. This pandemic has exacerbated the disparities and flaws in our healthcare system. So this really was the right time to introduce this bill. To kudos to Representative Kalra for introducing the bill at this time. Our infrastructure was just not there to handle a global pandemic. By the way, if you look at some single payer countries and see how they fared, they did much better than us during the pandemic. So what will AB 1400 do that would change this pandemic experience for us? And we know we are vulnerable to pandemics in the future. So CalCare does this by a couple of mechanisms. It improves our public health infrastructure. Included in that global budget that every institutional provider will receive, there will be the expense, the operating cost of maintaining a year's supply of PPE, occupational testing and surveillance, and contact tracing. We didn't have any of that this last year. Imagine how we could have better managed this pandemic if we had this in place. Secondly, and this is a topic for another day, but as we've alluded to many times, we have huge disparities in healthcare. Several places, CalCare intentionally addresses medically underserved areas, rural areas, or groups of people that are socially disadvantaged when it comes to healthcare, and it is putting resources to make sure we equalize access to healthcare. The virus doesn't discriminate, right? You want everyone to be equally healthy and equally able to fight off a virus. Our health is collectively entwined with one another. How will we pay for it? That is always the question of the naysayers. And I want to say something here. I have a 12-year-old son, and I told him I share this story. No matter what day of the week it is, no matter what is going on, when I ask him to take a shower, he has a zillion excuses not to take a shower. the water's not hot today, but I'm gonna play soccer anyway. Why not wait till after that? I did take a shower 3 days ago. I've had a time where he said I took a shower 5 days ago and that should suffice. The point is, he just doesn't want to take a shower. The stars could align. The fact is, he doesn't want to take a shower. So I'm just going to put that out there. When you hear, how are we going to pay for it? The question is not whether it is the right thing to do or the wrong thing to do. Removing the health insurance industry is absolutely the right thing to do. The question should be, how are we going to do it? Not how will we pay for it? Will we be able to do it? Should we do it? The question should be how. And if you're putting things in the chat, Erica, I can't see them because I'm just in my own little world right now. Okay, so first I want to point out, oh yes, there are red herrings all over the screen right now. I wonder why. This is a policy plan. AB 1400 is a policy bill. It articulates a vision for single-payer, patient-centered healthcare. It is not a funding bill. It sets a vision for where we want to go, and it articulates clearly that the first step would be pass the bill, and then the bill calls us to consider our federal revenues first, consider what money, and I'm going to get into this, what money will come in through the federal government through programs like Medicare, and then figure out what gaps are left, and then it calls the legislature to come up with a revenue plan to close that gap. It's written in the bill. It didn't need to have a funding mechanism spelled out. It's a policy bill, okay? Again, we need to ask our legislators, how are we gonna make this happen? Not, should we make it happen? And remember, under this bill, if AB 1400 passes, most Californians will pay less for more healthcare. Small businesses would no longer have to pay for employee healthcare. I have friends who own dry cleaning businesses, restaurant businesses. It's really expensive providing healthcare to your employees. You won't have to do that anymore. And as a patient, you're not going to be paying insurance premiums, copays, and deductibles. So keep that in mind. The average Californian will certainly be paying less. There's lots of misunderstandings about how our healthcare is currently paid for, and I think these are intentional. There's a really great UCLA study that spells this out very clearly. As it stands today, 71% of our healthcare is already publicly funded. Only 29% comes from private revenue sources like employee-sponsored group insurance or the out-of-pocket payments that we all make. 71% is already coming from our tax dollars. So as it stands today, our healthcare in California is publicly funded and privately managed. How do you like that? Do you believe that my public tax dollars should be allocated by a health insurance company's board of directors? I don't think so. So keeping that in mind, that we are only talking about this teal area. If AB 1400 passes, we have to come up with a way to close this teal. We have to fund the teal pie slice. But the pie slice is going to be much smaller under single payer because single payer costs a heck of a lot less. And let's find out why. Okay, first of all, by the way, this slide is from the website for America's Health Insurance Plan. This is their website, the health insurance industry's own website. Kip Sullivan, who's done awesome work when it comes to single payer healthcare, he lifted this up in a few presentations. So I'd like to acknowledge that it is in modeling him that I included this slide here. But what this dollar bill demonstrates is that as it stands today, 18 to 20 cents of every dollar we spend in healthcare goes towards administration when it comes to our multi-payer insurance companies. So as it stands in a multi-payer system, private insurance, 18 to 20 cents of every dollar are lost to administration. We already know that the administration costs of Medicare are much lower, 2 to 3%. There are countries around the world that have implemented single payer. They have all demonstrated about that same figure, that the cost, the administrative cost for single payer is about 2 to 3%, as opposed to the 18 to 20% that we are paying right now through our multi-payer healthcare system. So that little teal slice that I showed you earlier, it's gonna shrink a little bit right there because we're not gonna have to waste all the money in this in administration. We don't have to pay all the CEOs. of the insurance industry. 2, if Californians organize themselves as CalCare, we become a super consumer of pharmaceuticals and medical equipment. That means we can more aggressively negotiate drug prices. This is not a theory. This is in place already around the world. My inhaler, which I've become incredibly dependent on because of all the, that's a different conversation, the fossil fuel industry, another day. But my inhaler that cost me $300 in the United States, I had a massive attack when I was in Istanbul a couple years ago. I honestly thought I was going to die. We made it to a dispensary there. I paid $15 for the same inhaler. And I've heard that story from many people. So it is well known that in single payer countries, drug prices are much lower. Wouldn't you much rather pay $15 than $300, $350? So these are the 2 ways that that teal slice that we talked about here, this teal slice gets smaller. So it wouldn't even be the quantity that we've been talking about. Okay, so with CalCare and the resulting disbanding of the insurance industry, every Californian will be healthier and better able to pursue life, liberty, and happiness. Honestly, if you're not healthy, you cannot study, you cannot work. The American dream does not exist without health. It does not exist without single payer healthcare. How do we bring CalCare to life, and where are we right now? So as I mentioned earlier, and I think I'm gonna stop my screen share now. And hopefully I can stop shouting at my screen. I'm very passionate about this topic. I apologize. As we mentioned earlier, this bill was live until last week. Representative Ash Kara chose to take it out of committee right now. And what that means is we have 8 months till the bill comes before committees for hearings again in January. We have until then to increase public support for the bill and let our legislators know, our assembly members and our senators know that we believe every human being in the state of California has the right to equal and excellent health care. That we do not believe that the insurance industry is an ethical entity. The insurance industry, and I'd like to hear, honestly, you know, we hear people talk about, oh, we want the public option or this or that. I would like to hear one good reason to keep the insurance industry in play. So we have, folks, we have 8 months. We have 8 months to talk to as many folks as we can to help them understand what AB 1400 is and what it isn't. It's not a funding bill. It is a policy bill, okay? We have 8 months to do it. So the question is, how are we gonna get there? Let me look at my notes now, make sure that I did not leave something that I really wanted to say. Otherwise, I don't know what Erica has planned next. Okay, I talked about that. Yeah, I think I should take a pause there.
So what an incredible presentation, both the slideshow and you, Dr. Sarah, amazing. And also how joyful to get to participate in Ramadan. Thank you for inviting us. I'm gonna open it up to, I'm gonna open it up to questions. If you're okay with that. We do have Jason, our Facebook moderator. Let me find Jason and unmute him because
if anyone asks me which one of my friends' treats is the best, that's a question I refuse to answer. Just saying, putting that out there.
Smart.
Jason, do we have any questions from Facebook right now?
I have a few.
All right, go ahead.
So one is, so the bill has been withdrawn, question mark? And apologies if these questions have been answered because some people joined later.
Sure. I think, and I was trying to find the best word to use. Essentially, there were 2 choices. Either the bill could move into committees and start being debated right away, or Ash Kara could choose to hang on to it and bring it into committees for debate in January. That's what he has chosen to do. I personally think, and I know others disagree with me, I actually think that this is strategically in our favor. It gives us time. We can't pass a bill without the assembly members voting with us. This gives us that time to build support and get those votes. And I think that was Representative Kalra's thinking. Granted that the detractors are using that red herring of how are we going to pay for it. to say that we can't pay for it, so I can't vote yes on it. Again, it's a policy bill, it's not a funding bill. And Cheng Sim just put in the chat, it's not withdrawn. Yeah, paused, delayed is the best way to put it.
Okay, Jason, next question.
Okay, can you pick your own doctor?
Yes, yes, you absolutely can. Healthcare providers will register. They will, so their licensing is not going to change. That will still be managed the way it always has been through the Medical Board of California. But doctors, just like they do right now with insurance companies, you apply to become a provider. Doctors will apply to become providers with CalCare. And that means that they have to provide care to any CalCare patient, and they can't charge a dime or a nickel. And all the traditional rules for not prohibiting certain groups of people or excluding someone from your care, all of those will, of course, apply.
Thank you. Shall I keep going? I have two more.
Yes, Jason, go ahead.
So I apologize. One is asking for the URL link or access to your slide deck
Sure.
that you used for this evening.
Absolutely.
So I suppose we could post that on Facebook now?
Yeah, absolutely. The slide deck is available to absolutely anyone as long as they are supporting a yes position on CalCare.
And then I really like asking this one, and this is from our friend Lauren Steiner. She says, "Who is this woman? She is fantastic."
Oh, that's really sweet.
Last question. That was it.
Thank
Let me
you.
just tell you, there's been a lot of love for you on Facebook. People saying it was fantastic, and really, really a lot of good vibes happening on Facebook. And why don't we give out our if they want to request the slides, why don't we give them our email address so that they can request it, so that we can exchange some information and hopefully get them as a active supporter. But we'll still get you even if you're not, we'll still get you the slides. So I'm assuming you're going to be active.
Betty, can you send Jason our email address so he can post that now?
Yeah, I'm just going to put it in. I could do it.
I do see an interesting question in the chat.
Great.
So the question in there says, how can providers opt in or opt out? And so the bill articulates that they're going to come up with a application process. Just like any other insurance company, providers can technically say, I don't want to play. I don't want to be a CalCare provider. They're allowed to do that. What happens then is if I'm going to call that a non-CalCare provider. If the non-CalCare provider wants to see a CalCare patient, someone who would otherwise be covered and can go to a CalCare provider to receive, let's just say, free healthcare. So if that patient, a CalCare patient, wants to see a non-CalCare doctor, there has to be a written agreement that a contract between the doctor and the patient saying the patient is aware they could seek treatment at a CalCare provider's office at no cost to them, but they are choosing to see this out of this non-CalCare provider. So it has to be clearly articulated, and the non-CalCare provider has to check to declare that. I hope that answers that question.
So let's talk about what people can do to get this bill passed. Several things. One, calling your assembly member, making an appointment with your assembly member. Probably the person who requested the slideshow presentation was already onto this, but having your own presentations, whether it's in your living room with your friends, whether it's with your Dem Club, whether it's with your neighborhood council. We do have lots of resources for all of these things on our website. So if you go to HCALA.org, that stands for Healthcare for All Los Angeles, HCALA.org, and you click on the Take Action CalCare button, you'll see a CalCare tile, and you can click on that, and that takes you to all kinds of talking points, text baking opportunities, resources on how to make an appointment with your legislator. So please go to our website, hcala.org, click Take Action, and click the CalCare link. Let's see.
Erica, Cheng Sim asked us to make an announcement.
Yes, go ahead.
So we want to invite everyone to participate and stand with our seniors. So there's a Save Our Seniors rally in Boyle Heights at 2 p.m. on May 1st. The website to learn more is saveourseniors.network. And Healthcareforall Los Angeles is a co-sponsor. They ask you to wear black to protest the developer that wants to evict vulnerable Japanese American seniors from their nursing homes in a pandemic. And the issue of nursing homes is also a really important aspect of the CalCare bill. If anyone has had a loved one in a SNF or in a nursing facility, if you want to see unethical business practices, that's the place to go. And so CalCare would fund. Another thing I really love about the bill, it prioritizes maintaining relationships and not disrupting community. So the bill prioritizes keeping people in their homes with their families and in community for their long-term care needs. We don't want to collect our elderly in homes, in nursing homes where they're disconnected from friends and family. That is not how humans are meant to live. We're meant to live in relationship. So I just wanted to throw that in. The word nursing homes always, it's another experience that's close to my family. So that's another great aspect of the bill.
Yeah, and I just want to say, so the address for the Save Our Seniors rally is at 325 Boyle Avenue, zip code 9033, but you can also go to our website, that's hcala.org, and click calendar of events, and you'll find this on the calendar of events as well. But thank you, Chung Sim, for putting that up there. Any other, we're coming up at 8:25, so we have a few minutes left. If there are any other questions, I so appreciate the questions from Facebook. It sounds like we have some people who might be newer to the movement, and just really welcome your questions.
Erica, I'm like debating. I'm like, should we lean into the biggest the biggest can of worms, that whole $400 billion price tag that detractors will allege the last single payer bill was going to cost?
I'd say yes.
All right. So there is the last single payer healthcare bill was SB 562 in 2017. And yes, and kudos to, I was not engaged in the movement back then. And I got to point out that as someone who is newer in this movement, I love the spirit of collegiality, camaraderie, and coalition building around the single payer movement in California. This is not an egocentric movement. This is people coming together to support one another and to love one another, and I really appreciate that. But going back and doing a little study of SB 562 and the Senate floor analysis, I'm finding that there's a misunderstanding of that analysis. So in 2016, the total cost of healthcare in California was projected to already be $367.5 billion. Healthcare was already costing us $367.5 billion. And as I mentioned, 71% of that was already publicly financed. You and I were already paying for 71% of the $367.5 billion. What the analysis was saying was that if that the current healthcare system, what we have right now, the mess that we have right now, if it was expanded unchanged to cover every Californian, our costs would be raised to $400 billion. It did not mean that SB 562 had a $400 billion price tag. Furthermore, the analysis didn't take into account the well-documented reduction in healthcare spending with the single payer system due to, like we said, the administrative cost decrease and the decrease in pharmaceutical and medical equipment costs. Again, we have seen these reductions in Medicare, we see them around the world. So if you took all of that with the Senate floor analysis, what you can say about it is that it would actually, so I just wanted to point that out. The bill did not have a $400 billion price tag. It was saying if the current system was expanded, it would cost us that. But given all the savings of single payer healthcare, we would actually bring down the total cost of healthcare while covering every Californian to $331 billion. That's less than $367 billion that we're already paying. And again, 71% already publicly financed. Just wanted to put that out there.
Thank you. I'm so glad you did. That's so important. We have another question from Facebook. Go ahead, Jason.
No, asked and answered. Thank you, though.
Okay, great. So I'm thinking about, it sounds like we've got some single payer supporters joining us from outside of California. And I want to encourage those in California to share this this recording, share this with all of your California friends, because this was such a beautiful presentation of this bill. But for those of you outside California, you know that as California goes, so does the nation. And we believe that if we can make it happen here, we can make it happen everywhere. So we would love your support as well, even if you are outside California. This is for all of us, but you know, our tactic is we're starting here. California is the world's 5th largest economy. As Dr. Ron Birnbaum said the other day, it's not a question if we can afford the car. We can. We are the richest state in the richest country. It's just a matter of, are we going to put the car totally on a credit card? Are we going to pay half cash, half credit card? Are we going to do Venmo? That's what this is a question about. So thank you so much for joining us tonight, Sarah. Thank you, all of you guys out there on Facebook. Thank you, Healthcare for All Los Angeles leadership team, our first 100 days team. Special thanks to our tech crew tonight, Paul Newman, Jason Small. Thank you to Director Maureen Cruz, Co-Chair Betty Dumas-Toto. Thank you, social media team, for getting this out there, Bronwyn Major. And just thank you to all of our leadership team members. We so appreciate you, the in front of the scenes, the behind the scenes, and of course, thank you, Dr. Sarah Deen, and happy Ramadan, everybody. Good night.
Thank you so much. Ramadan Mubarak to everyone observing.